So it's my great pleasure to warm welcome you to this ALSP session today on behalf of the United Leukodystrophy Foundation. So we will have, can you put on the slides? So we have today a very interesting and nice program. So the first which you can see here. So we have one talk from Jennifer Altman-Murphy, which is virtual. The other ones are here. So I'm very happy to have you here as a sophisticated speaker for this session. So, well, let's start with the first issue, an introduction, when to think of ALSP. Next slide. Oh, okay. So what are we talking about? Well, ALSP, adult onset leukoencephalopathy with axonal spheroids and pigmented glia, is a name. It's a extraordinarily long and very difficult name, but it's describing what is happening in the brain. So what you see in the brain is some changes. You see here the brown dots, which are disconnected axons and swollen axons. And this we call axonal spheroids. And pigmented glia is also seen in the brain slices, which gives you an idea that these glia cells, which are very important for the cerebral function, are diseased. And then they change their color and introduce some pigmentation. So this is a rare genetic disease. It's autosomal dominant. It's a neurodegenerative disorder, which is causing two things. One is a loss of brain white matter. And the second is a loss of function of very important cells that are in the brain, which we call microglia. Microglia has a lot of functions in the brain, so it's extremely important for the correct function of the brain that you have a nice and healthy glia. So, and on these glia, there is a receptor which we call CSF1R, which is genetically defected. So this is leading to a dysfunction of the microglia. This is also leading then to neuroinflammation and to neurodegeneration. Well, the disease is probably much more frequent than we think. And this is, let's say, the main issue of my talk, to make this clear that we have to think of this disease more frequently. Some say that it accounts for 10% of all adult leukodystrophies. So this is very, that's quite a lot. And but it's hard to diagnose these patients as early as possible. But it's important to diagnose early because this is a very rapid progressive disease, which leads to incapacities and deaths within those 3 to 6, 7 years. So this is a very devastating disease. But due to the overlapping clinical and radiological presentations of ALSP, is frequently misdiagnosed in other neurological disorders, for example, in primary progressive multiple sclerosis. Nevertheless, we have no approved therapies, which also highlights the critical need for new therapies and to slow this rapid progression of the disease and to improve, of course, survival. So how are the symptoms of this disease? So we have two big symptom complexes. One is the cognitive disorders, which can be personality changes, anxiety, depression. You can have difficulty at work caused by these personality changes, difficulties in decision-making, appropriate behavior, memory problems, and speech problems. So this is one big complex that most of the patients had early on. And this comes together with motor symptoms like gait and balance problems, stiffness, apraxia, maybe gait apraxia, incoordination tremor, and also swallowing and speech difficulties. So, but these symptoms are present in the disease, but they're not specific for the disease. You can have the same symptoms in other diseases, and this is leading to a misdiagnosis in half of the patients. And there's another quarter of patients which you did not recognize the initial correct diagnosis. Then there's a lot of diseases that you may misdiagnose because the symptoms are very similar. For example, in MS, in other kinds of dementias, like frontotemporal dementia, some familial leukodystrophies are very similar to this leukodystrophy. And, which is very important, other diseases, I will show you some examples later on, including cerebrovascular diseases or Parkinson's diseases, and many other neurodegenerative diseases. So what are why is that overlapping? Why is the initial symptoms? For example, here you see a comparison between a frequent disease, multiple sclerosis, and ALSP, and you see that cognitive impairment is present in both diseases initially in more than half of the patients. So more than half of the patients, both in ALSP and in MS, have problems at workplace, has forgetfulness, has impaired comprehension. So people recognize this and then say, wow, you are making mistakes at a working place, and what's wrong with you? So this is the initial, people recognize that there are cognitive deficits, but it's not specific for ALS. It can also be MS. So frequently, these patients with ALSP are misdiagnosed as multiple sclerosis. Yeah. The same is true for the behavioral or psychiatric symptoms. You see here, it's a little bit more frequent in MS, but it's frequent in both of these are percentages here. So apathy, aggression, depression, or anxiety is present in both of these diseases. There's a little bit of difference in the motor symptoms of these diseases, but still you have the symptoms in both of these diseases. So it's again, you can misdiagnose ALSP as having multiple sclerosis. But in terms of the motor disturbances, there's a little bit more of coordination problems, especially gait apraxia. So people are not able, they don't know how to walk anymore. So we call it apraxia. And so it's finally leading to impaired mobility and shuffling gait. So here there's an expression, why is my nanny walking like a penguin? So these are things that happen in daily life. And also there's speech difficulties as initial symptoms in both of the diseases. So just looking at the symptoms, you cannot really decide if this is ALSP or is this multiple sclerosis, for example. Yeah. So what about the MRI? So is the MRI different? Can we use the MRI to differentiate multiple sclerosis from ALSP? Well, because we know there are quite typical changes that we see in MRI of ALSP. We see, for example, the bilateral white matter abnormalities. You see here, for example, on both sides, these white spots. You see a corpus callosum atrophy, like here, or cortical atrophy. You see bilateral changes in the corticospinal tracts, which are the tracts for the motor, for the walking, for example. You see here, there's changes in these corticospinal tracts on both sides. Or you see signs like small calcifications here in CT. And you see diffusion changes, which are very typical. I come to that back later for cerebrovascular diseases. So we could say there are typical signs for ALSP and MRI. So this can maybe differentiate ALSP from MS. No, it's not. Yeah. So if you compare ALSP and the changes in the MRI with the MS, you see you have white matter hyperintensities in both diseases. You have corpusculosis irregularities in both diseases, atrophy in both diseases. Maybe the calcifications but the calcifications are not always present in ALSP. But once they are present, there may be a difference to multiple sclerosis. But so there is a substantial overlap even in MRI. So MRI is, again, not a good tool for differentiation between MS and ALSP. So I give you other examples here. These are very important, I think. So that's why I took some examples from this side. For example, there are some descriptions in the literature, and we also had the experience that, for example, acute right-sided paralysis, which is very typical for cerebrovascular disease, for a stroke, can be present in ALSP as well. Yeah. So even it can be recurrent stroke-like episodes or transient left side hemiparesis, right side hemiparesis. And again, in addition to the clinical signs that are typical for cerebrovascular disease, for stroke-like episodes, but this is ALSP, the MRI is also not good for differentiation here. Indeed, you find changes in MRI, in ALSP that are typical for cerebrovascular disease. So I guess that many patients, which we see every day in clinic, with stroke-like episodes, a little bit of cognitive deficits, maybe older patients, are misdiagnosed as having cerebrovascular disease strokes, minor strokes, but they're still having ALSP. So this is an important differential diagnosis when we have to think of. Another big group is movement disorders or Parkinson's-like disease or gait disturbances, which are combined with apraxia and cognitive impairment. I have examples here in two patients. Sorry. So I run these two patients. So the one patient here on the left side is 40 years old, and you see his gait abnormalities. He had these progressive movement disorders, which it reminds a little bit of Parkinson's disease since 4 years, together with a cognitive decline. In addition, you find dysarthria and paresis and apraxia in this patient. But in the other patient, you see he has walking disabilities. This really looks like Parkinson's disease or chronic cerebral vascular disease. He had a transient hemiplegia 2 years ago. Later on, he progressed with these gait abnormalities. He had also dysarthria and cognitive deficits and behavioral changes, which are very prominent in the end. So you see this Parkinson-like movement disorder. He also had a rigor and bradykinesia, which are typical signs of Parkinson's disease. Yeah, he had no ataxia, but this severe apraxia. But one thing is, at that point, I would show you, it's so important to have the family history. Yeah, we sometimes forget in clinical stress to ask for the family history. But here, for example, the brother is completely demented, living in a nursing home at age 32. Yeah. His mother, grandmother, and 2 aunts died from early dementia. This is so typical for this ALSP. So if you're not asking for that, you would not find a diagnosis. Yeah. The same is true for this other patient he had. He had 2 not pre-symptomatic daughters. The mother was demented. She was said to have strokes or even cerebellar tumor. There's, of course, no tumor, it's white matter abnormalities in the brain. Her sister, the sister of the mother, is bedridden, psychotic, and the grandmother also died from a suicide, being depressed previously and demented. So this also is a family history which is very significant and leading to this disease. So due to this overlapping clinical and radiological presentations, ALSP is frequently misdiagnosed as other neurological disorders, including primary progressive multiple sclerosis, including all kinds of dementias, like Alzheimer's disease or frontotemporal dementia. It's including vascular encephalopathies, both genetic or non-genetic, and atypical, I would say, Parkinson's disease. So we should remind this, we keep this in mind in our everyday practice. So why not do the genetic testing? Well, genetic testing for many people has some barriers. Yeah. So, for example, there are relations and concerns about a broader impact of the genetic testing in everyday life. There's a fear of getting the results, also for financial and logistical concerns. So there are a lot of barriers. Many people say, well, I don't want to know if I'm diseased, yes or no. I just want to know it. Yeah. And there are a lot of concerns, of financial concerns, insurance concerns, and so on about the genetic testing. So there's a lot of problems that's leading that many of the patients are not willing to do a genetic testing. So we should overcome this, because on the other hand side, there's the potential motivators for genetic testing. For example, just in case there is a treatment, you have an access to this treatment. If you don't have a diagnosis, you don't have an access to the treatment. So currently, of course, there's an access to clinical trials, probably. Yeah. So these possibilities, or any kinds of treatments, correct treatments, and adequate treatment, is sometimes only possible if you know the correct diagnosis. So this could be a highly motivation for the patients to enter a genetic testing. So in conclusion, in this introductory talk, I would say that ALSP has overlapping symptoms to very common neurological diseases, like cerebrovascular diseases, like Parkinson's diseases, and all kinds of neurodegenerative diseases. So it's very important to differentiate this. Just in case you're not receiving the diagnosis, this may lead to a delay in initiation of an appropriate therapy or the chance to be part of a clinical trial. Otherwise, we know ALSP is progressing rapidly, and there's only a small window of opportunity for treatment. So the treatment, of course, is better the early. It's more effective in early phases of the disease. So genetic testing should be done as early as possible and very liberal, even in cases where you don't know really what is this a cerebrovascular disease? Is this a chronic MS? Is this strange Parkinson's-like disease? You can think of, if you have these white matter abnormalities in the brain, you can think of a genetic testing. So you should do that much more frequently. So the goal must be to minimize misdiagnosis and expedite access to potential treatments. Genetic testing should be done as early as possible in patients with white matter abnormalities and early onset cognitive decline, unexplained behavioral changes, atypical Parkinson's syndrome, cerebrovascular diseases without explanatory risk factors, or where you see a family history of neurodegenerative diseases. So thank you for your attention for this talk. So now, thank you very much. So if there are questions, just don't hesitate to ask me or anybody who is in front here. So it's a discussion. But otherwise, I'm happy now to present Caroline Bergner from Leipzig Research Center in Saxony, Germany. And she's talking about assessments of asymptomatic patients. Very important question.
So welcome, everybody. I'm very happy to be part of the session and to talk now about why we think that asymptomatic patients should be screened, and also why we think that screening of the families and genetic testing of families is very important in CSF1 receptor encephalopathy. I'm from Leipzig in Germany, and I think some points that I will tell you might be specific also to the German system, but I hope some things or a lot of things are also transferable to how it works here. So these are my disclosures, and I want to start also with histopathology briefly. So Wolfgang already explained it nicely, but I find the disease name or the disease names is always very confusing, and also for patient might be very confusing. So the disease has been described very early, actually. It's been described in 1936 for the first time by Borgert and Van Nissen. And this was a histology description where they found the characteristic features of the axonal spheroids and these strange immune cells in the brain that are roundish. There are only a few, they are scattered, and they have these strange pigmentations. So this was so outstanding that they named the disease, or the disease in the long run was named after the histopathologic features as adult onset leukencephalopathy with axonal spheroids and pigmented glia. And only later we found that this histopathologic phenotype is not just associated with one mutations, but that we do have different, and this is making the things maybe more confusing, that we not only have CSF1 receptor mutations, but also, for instance, ARS2 mutations, or probably also others that lead to this common end stage phenotype of the disease. And this is why now often the disease is also called CSF1 receptor related leukencephalopathy, because this name is more specific to the specific genotype and the pathology that is associated with the variants in CSF1 receptor. The CSF1 receptor is situated on immune cells in the brain, and it's important for their activation, for their survival, for migration, for division. So it's doing a lot of things there. And this is why it's very likely that any treatment that we could develop should most likely target microglia cells, immune cells, by either modulating these cells or by even replacing the cells with healthy ones. And this is indeed one approach which has been adopted already. So we have done hematopoietic stem cell transplant in ALSP, and the reasoning behind is that if we condition the patient there by eliminating all the patient-derived blood cells and then replace these cells by donor cells that are healthy, then these cells most likely can invade the brain and replace the deficient microglial cells of the patient. So this has been done in about, I think, more than 20 patients by now worldwide, and I think the experience are quite encouraging. So in Leipzig, we have transplanted 2 patients with ALSP, and what we find is that in the first months after transplant, we often see a deterioration in the neurologic condition of the patients. This can be recovering, but we have followed these 2 patients now for 4 or 5 years already, and we've seen that the long-term stabilization of the patients is quite good. So this is a cognitive testing of one of the patients. right before the transplant, and then 15 and 30 months after the transplant, and you can see that it's quite stable. We have a bit of a drop in the processing speed right after the transplant, but then in the long run and also the next examination were quite stable for this patient. So this is very encouraging. And in addition, I mean, we have now drugs in the pipeline. We have studies that are ongoing, which we will hear about more today as well. So I think this is good news. We do have approaches how to treat patients with ALSP. But what is the optimal time window to do that? We know that, as I said, we have this first progression of the symptoms after the transplant, but we can reach stabilization probably also in more advanced patients. So the ones that we transplanted, actually, they had already moderate cognitive impairment. If you look at the MRI here, it's about these white spots here, and they are comparatively large already, but still we could stabilize these patients. So probably we can also transplant at least in moderate stages. We don't need to only do it in asymptomatic patients. We have some or a little bit of data that there might be some factors that could be beneficial for the outcome, like primarily motoric symptoms and not cognitive symptoms. Younger age, shorter disease duration, and slower disease course could be beneficial, but we don't know well yet from these 20 patients, of course. But what we know is that improvement after transplant is very rare. So what we reach or what we can promise, or not promise, but tell the patients is what you should expect is stabilization, but not improvement of the disease or recovery. So this, and also the likelihood of a better outcome for sure, is the reason why we would always say the earlier the better for whatever treatment we have. The earlier you started, the better will be the outcome. And this is why I think most of us think that genetic testing and also family screening is so important. We don't have any newborn screening. We cannot identify thereby any more patients. So we really have to rely on the patients to inform their relatives about the disease, and thereby to enable them to get a diagnosis themselves and to enter screening programs that will enable them to have the best possible outcome if the disease starts. So it is an autosomal dominant disease, which means that every patient has a 50% likelihood to transmit the gene to its offspring. So, and at the same time, if you inherit it from your parents, all your siblings will also have a 50% likelihood to have the disease. So this is why you should really tell your family about it. Everyone can decide himself if he wants to be tested, but as long as relatives don't know about the disease, they don't have this option and this decision. So if we identify gene carriers by family screening, what would we do with them? We know that the onset of the disease is most in the 4th decade of life. If we look at the manifestations at the different ages, at age of 27, we have about 10% of patients. These data are not completely up to date, but I think they are quite reliable. If we look at the age of 43, we have about 50% of the patients, and at age 60, we have about 95% of the gene carriers that have manifest symptoms. So this looks as if we can somehow adapt the screening to the age. And and could also, I mean, if we once would know about what would be triggers of the onset of the disease, of course, this would also be an option to say, well, we have certain conditions where we screen more often and ages where we screen less often. But I think we are not at this point yet. So what we do in Leipzig, but I don't know, there might be centers that do it differently, is that we start at the age of 18. So if we know someone is a gene carrier, we start with 18, and then we screen every year with our regular assessments for first symptoms of the disease. And we do this by clinical assessment. Wolfgang talked about the typical symptoms of the disease. So we have motor symptoms, we have cognitive symptoms, can have different other neurological impairment that we want to see in our neurological examination. We also do a battery of cognitive testings. We know by now that typical for white matter affection or white matter cognitive decline is that we have difficulties in executive function and a loss in processing speed. There are other domains which are less affected, but we make sure that our cognitive assessments are large enough and that they really cover these domains so that we can have the best likelihood to detect these early symptoms. And then, of course, we also do MRI once a year. We sometimes have patients bringing their MRI from somewhere outside. I think this is also fine for us, but we just prefer to analyze the data as well at our center. And we try to make sure that the way the MRI is done is always comparable between the different scanners that are used. There are also some data about biomarkers. We know that NFL, for instance, which is a protein that is increased through exon decay, is elevated in patients with manifest symptoms. And we will hear, I think, later on about this the natural history data, where we potentially will in future hopefully have more biomarkers also to detect the disease onset. There's one thing which I also wanted to briefly mention to you. So we had one patient in the last year who was a brother in a family with many affected patients. So he had 2 affected brothers, affected sister, mother, grandmother, and aunt. So he was really burned also by the experience of the deceased relatives. And he approached us with a request if it's possible to also do prophylactic transplant. So to not wait for the onset of the disease, but to transplant before. And I think this is an open discussion. So there is a publication about a patient that has been transplanted without any symptoms. We brought this to our ethics committee at the university and discussed the case. But in the end, the recommendation of the ethics committee was not to go for a prophylactic transplant. I think the reason is that transplantation still is a very risky treatment. So we have about 10%, at least 10%, 10-15% of the patients that die due to the procedure. We have side effects that can be long-lasting. And to put someone on the risk of such a treatment without knowing when or if the disease will start is something that the committee did not recommend to us. We also don't know if the treatment would work the same as it does when the disease already started. So I think there are too many open questions to really go for a recommendation of such a risky treatment. But I think this is also one point why we are not at the end of what we want for the patients. So we have good experience and I think encouraging experience with the transplant. I think this is really good news, as I said, but I think we still need more treatment options, especially for something maybe that could be prophylactic or something for patients which are not amenable to a hematopoietic stem cell transplant. And this is why I think it is good that we have potentially other things in pipeline, or that we should hope for other options for the patients here. So to summarize, we know that ALSP is a severe and debilitating disease that the lifespan is very much reduced in patients with ALSP. We do not have an FDA or EMA approved treatment yet. We have good experience with HSCT in growing number of patients worldwide. And this makes it crucial to go for an early diagnosis in patients and in relatives to enable screening programs, which I think we should implement at all the reference centers that treat patients and relatives with ALSP. What we do are regular annual assessments with MRI, cognitive screenings, and clinical examination. I think this is something we need to discuss in the next years. What is the right approach to this? And I think it's good news that there are other treatment options that are investigated, and hopefully we will in future have more options to offer to the patients in the clinics. Thank you. And if there are any questions,
We have questions, yeah.
That's great, and such a nice overview.
Do we need a microphone?
Yeah, wonderful overview. And you know what strikes me as
important is this transition from diagnosis and early disease to transplant decision, and how to define what is early disease. And I think one of the big gap we have is there's so much anxiety obviously involved with this, and it's very hard for patients and families in that pre-symptomatic stage to know, what am I to expect? How do I deal with this uncertainty? And, I see Lisa Schaefer here and others. I mean, we have wonderful psychologists. There's so much that I think we could provide in terms of support and counseling, and you might be doing it, I just don't know about it. Is there a way to learn about best practices in supporting families and sharing experience of uncertainty so that it can be managed better? Because I think that there is this sense of doom and gloom, and can one somehow alleviate that by saying, there are many people who have gone through this and they're fine. And once this happens, this is the steps we will take, and shared knowledge is good knowledge. It helps everybody, feel more confident about life. So I know it works for me. So.
Yeah, I think this is a very important point. And this is something that really also we, of course, experience, that these regular assessments, they are very important, but they are very burdensome also for the patients to go to the scanner. It's always so many people, patients tell us this is the worst day of the year if I have to come here and to go to the scanner, because I'm expecting something very, very bad. And I mean, for me, it's always, I'm sitting there and I'm thinking rational, and I think, well, this is good that you can do it, because if there's something, we can do something. If we don't see it now, we can't do anything about it. But I always have the feeling there's something of what I don't understand. I mean, it feels completely different for me if I just go rational and tell the patients how it is. And I think this is very important for us to reflect. And the feedback from patients is very important here as well. And I think your idea is perfect, to think about how we could share experiences, not just with the disease, but also with treatment, and how do you go from the diagnosis to something which has a good outcome. And this could be encouraging. I mean, truth is that not for all, it's the same story and it's different for everyone, but I think there's quite a high percentage which have made good experiences, and maybe this is one way how to make it more comfortable for patients to go to these screenings.
And in addition, what if you have the changes in the MRI, no clinical symptoms, what will you do? Is this the right point to do something, to have an intervention? Yes or no? We simply don't know, because this is information we need to gather in all sense. There was a question over there.
Thank you. I just wanted to follow up on Dr. Eichler's comments and the discussion. And so I'm Erin Sullivan, Executive Director at Sisters Hope Foundation. And I think your point for providing patients and families this kind of emotional support as they go through these very trying, whether they're asymptomatic, symptomatic, I mean, it's very emotional, it's very mentally taxing. And we're global. We are working on building out our global ambassador program currently. So we're willing to accept any and all patients that y'all send our way, connect them with support groups, whether that's asymptomatic support groups, caregiver support groups, patient support groups, and help you as you're trying to communicate these intricacies of the disease. So just wanted to throw that out there, that we're always available. And if you need resources to give to your patients to direct them back to us, we're happy to make those available. Yeah,
this is extremely valuable. I think for us, sometimes I try to refer patients, but we have a lot that have language or something in English is kind of writing them off, but still I think there are some which will, and hopefully we will have the German equivalent or something for them.
Onto that one, that's why I brought up the Global Ambassador program, because the goal is to have
Wait,
That's why I brought up the Global Ambassador Program that's recently established. So we're working right now to make connections in every country that
That's good.
have
Yeah.
known patients, and we'll be working with either patients or families there that will be able to translate
Mhm.
to
Great.
try to overcome the language barriers.
That's great.
More questions? Then thank you, Katie. I hope the virtual presenter is already online.
Hello.
So,
Here.
okay, we can hear you, but we can't see you yet. So we're waiting for Jennifer Ortman Murphy. Ah, here she is. Very good. So Jennifer is working in Pennsylvania, and she's talking about symptomatic treatment and follow-up of symptomatic patients. So we're happy to have you here.
Thank you so much for having me. I'm sorry to not be there with all of you in person, but appreciate the opportunity to Zoom in today. And my daughter also appreciates that I can see her end of camp theater performance. So thank you all. I just have some disclosures I would like to share. And I guess my talk here is really launching off of this wonderful discussion that has been started, an introduction into understanding this complex disease that affects so many people that are here and throughout the world. And in my own experience of diagnosing and then understanding the treatment path and the management path, I sort of developed this, picture of a path that always, of course, has to start at genetic testing to get a diagnosis, like Dr. Kohler said earlier. And once you have the diagnosis, you have to build a multidisciplinary team care approach to address symptoms and longitudinal management. And that's what I'm going to talk about today. But this is always within the context of many other things happening, having advocacy support in the research community, having natural history studies, having international collaborations, because we need to build consensus, even on a few things that have been mentioned today, including the name and the longitudinal care that I'll talk about today. This is what we do, and you heard a little bit of from Dr. Bergner about what they do, and in some ways we align very nicely, but we can share those practices with others. We need to partner and have been very fortunate here to partner with industry to develop therapeutic interventions. And then we need to have the appropriate models to understand disease pathogenesis, because we all want a disease modifying therapy and improve quality of life. So in these next few minutes, I'm going to kind of go through sort of my approach for a multidisciplinary team care approach with the people that see me, which I think is based on the literature for CSF1R ALSP. I'm just combining them together, so we're covering all the bases here. From both of our experience and what other people have reported, and also within sort of the larger context of adult onset leukodystrophies. So one of the issues that have been brought up already is that CSF1R ALSP is highly variable and heterogeneous in how people initially present and symptoms they develop. So everything that we're going to talk about here does not necessarily apply to everybody, but we have to go through and ask all the questions to make sure that we're addressing everyone's needs. And you've already heard about some of these, but I'll just kind of go through the list. That there can be changes in mood and behavior. These can be with irritability, apathy, losing interest in hobbies. There can be changes in speech, understanding, ability to do your job, follow directions, drive, pay bills, get dressed. You can change your gait and your ability to walk. So there can be shuffling, slowing down, weakness, muscle tightness, stiffness, feeling off balance, and falling. There can be changes in bowel and bladder habits, changes in sleep habits and quality. People can develop headaches. People can have episodes of loss of awareness, or obvious episodes of that involve the whole body with abnormal movements, or otherwise known as seizures. And so now I'm going to sort of go through each of these symptoms and how you can think about them, have the discussion with them, with the different people that you look to for your medical care. So for changes in mood and behavior, those are sometimes some of the most insidious to identify and describe. And at first pass, this could a change in your mood could be in response to getting a diagnosis. And we try to support that adjustment, which is in frustration, and you know, feeling kind of lost and wanting to know what kind of support you need, which is often happening. We start with the support from the genetic counselor who's trained in providing that support. But often people need additional therapy. In addition to family support, caregiver support, it is can be really helpful to have access to therapy outside. And one of the things I tell my patients in the US, there's this website that I've linked here, psychologytoday.com, and you can actually plug in your insurance and your zip code and get a list of psychologists. So you don't, if you don't have a known referral to go to, there might be access to people that you wouldn't have otherwise heard about. You can discuss whether a medication is needed for anxiety or depression, and that discussion can be with your neurologist, a primary care provider, or even a psychiatrist if you've been referred. We typically refer people for a neuropsychological evaluation, and there have been reports out there for the specific battery and specific findings that you see in CSF 1R ALSP from Beth Rush at Mayo Clinic Jacksonville with her recent report. And getting this broad evaluation, which is certainly time consuming, can give you a baseline. It can give you a better idea of where to focus therapy and recommendations, and also provide other avenues of support. And then we typically start by referring to social work for support in navigating the diagnosis and complexity of care. Other changes that seem to represent changes in cognition or changes in speech, in understanding, ability to do your job, to follow directions, to drive, to pay bills, to get dressed. These can be defined more specifically in conjunction with cognitive testing that's done with your visit at your neurologist, or with neuropsychological testing once referred. A speech therapist can establish whether there's changes in speech quality, ability to make speech, or in addition to slurred speech, which are all changes that can happen, as well as I think Dr. Kohler brought up apraxia. Can be speech apraxia, which is quite difficult to diagnose outside of experts, and you really need to work in collaboration with speech therapists that have a good understanding of this. And then there's also options for cognitive therapy. Now, while we don't have specific cognitive therapy interventions that have been defined clearly for CSF1R ALSP, they have been defined for other overlapping disorders. So this is where it's maybe not bad that this disorder has been misdiagnosed as other more common disorder, because we can take advantage of the symptomatic therapies that are used in those other disorders and say that this is like an atypical Parkinson's, or this is like frontotemporal dementia. Why don't we do those therapies that are being used? So other symptoms that can show up can be changes in gait, like shuffling, slowing down, the weakness in legs or arms, muscle tightness, stiffness, or feeling off balance and having falls. So we can define that in the visit. There's different tests that we can do during a visit to define these. We can refer to physical therapy to target strengthening and stretching. And again, we take advantage of the knowledge that's actually out there for other more common disorders, and ask and instruct people or refer to known physical therapists that are trained in multiple sclerosis, for example, because they already know how to deal with these symptoms. We refer to occupational therapists to identify appropriate assistive devices, including walking aids, if spelled correctly, as well as discuss medications for spasticity and muscle tightness. And so common ones that we start off with are baclofen and tizanidine, but there's many other options, including Botox injections. And when we go down that route, we start to refer to a physiatrist, which is a medical specialty, otherwise known as physical medicine and rehabilitation, that provides this integrated care approach to address each person's physical, medical, vocational, and social needs. So that ends up being an important partner to have on board. Then we talk about bowel or bladder habits. Typically, once we've defined what they are, you can always trial a medication empirically, sort of test out and see, does this help? I like to refer to my urologist that we use within our, so I'm MS trained. So I typically refer to the urologist that I work with frequently to evaluate for neurogenic bladder. And then they do a series of tests to figure out, is this an overactive bladder or a bladder emptying issue? And depending on what they find with those testing, that will individualize the approach with either medication management or potentially Botox injections or other approaches. And sometimes just addressing the bladder issues can help any GI issues that are also showing up. And an important topic of discussion that may get overlooked is talking about sleep habits and quality. Because of course, people can develop sleep apnea, have trouble falling asleep, staying asleep, and not feeling rested in the morning, having headaches in the morning. These are all sort of flags that something's going on with sleep. And there's interventions you can do, even starting with melatonin at night to sort of reset someone's sleep cycle if they, have reversed when they're awake and when they're asleep, or having trouble falling asleep. There are also other medications that can help induce sleep, but often a sleep study, if those interventions don't help, can better define this. And it's really important to think about this in the context of all the other symptoms you talked about, because your sleep can be affected by your mood. It can be affected if you have to get up overnight to go to the bathroom. And so if you address each of these issues, your sleep might end up becoming better. And then one other thing that comes up that is actually a really fast growing field is management of headaches. And so to be able to better treat that and avoid having this symptom, we typically start with having people have to keep a headache diary so that we can keep track of frequency and intensity, because now there's so many choices for treatment. And then you can discuss change in habits or then medical options for either preventing headaches or stopping the headaches once they come on. And again, this is one of those symptomatic interventions where many of the medications we use to treat headaches can do double duty and treat other symptoms like mood and sleep. And then for episodes of loss of awareness or more obvious events that sound like seizures, you might be recommended to get a routine EEG to establish the type of seizures, but there's you usually recommended to start medication to prevent seizures after one or more seizures, especially if you've been diagnosed with this disorder, because it's known to be associated with it. And again, there's many different types of medications that can treat generalized seizures or more localized seizures that can be trialed, but can also perhaps overlap with treating headaches and mood. And then other really important points that can come up in this review of systems is fatigue, tremor, and pain. So for fatigue, again, that may be multifactorial, whether it's due to having the disorder itself versus poor sleep, mood changes, that having trouble getting around. So you're just working so much harder to get everything done. And so if you address each of those individual symptoms, but there's also medications that, we've trialed in other disorders, including MS, that specifically target fatigue, and also and could be trialed and have increasing access for other disorders. And then pain is an issue that could come up in so many contexts and is important to have the discussion. And then once you've gone through this sort of neurologic review systems, you really have to have a holistic approach to everything someone's doing to take care of themselves. And so that brings up the discussion of diet and nutrition. Have someone's eating habits changed? Their interest in eating, are they eating more or less? Is there weight gain or weight loss? And often people will ask, what diet should I be following? And again, we don't know the answer to this question quite yet for CSF1R ALSP. That has not been defined. So, the first recommendation that I'll start with is a heart healthy diet. And there's many different types of heart healthy diets that are from around the world. And there's not one of them that's better than the other necessarily, but sticking to the one of them is definitely a good place to start. Doing some form of activity or exercise is protective in some ways. We don't know, a prescription to say you must do this number of reps or this type of exercise, this number of times per day necessarily for each symptom. But there's a lot of basic science research that shows that doing exercise interventions can promote repair or stabilization or improvement of movement, so and even cognition. So that's definitely something that we promote and discuss and talk about to incorporate that into your daily life. And then we also talk about vitamin supplementation. And my general approach is, if you're not taking too much of something or one thing and it doesn't hurt you, then why not? And it's also not too expensive. And then other sorts of things are, how are you spending your day? Has that changed? What sort of support and community and interactions will help you get the most out of your day and what you're doing? So one of the things that Dr. Bergner had brought up was the longitudinal testing and management for people once they've been diagnosed but are pre-symptomatic. And in the case of once you are symptomatic, this is not completely defined. But one thing that we recommend is to do at least annual and maybe more frequently surveillance brain MRIs to see how things are changing. Is this active, at least by MRI? In the US, clinical MRI should be covered by insurance, but you can also get research MRIs, either 3 Tesla, or now we're also collecting 7 Tesla, that can potentially be captured in your medical record, so you're not, doing too many things at the same time. And you can propose to follow other things with longitudinal testing. And so in our clinic, we collect optical coherence tomography, which is a potential marker in this disorder. It's been developed from my background in MS, because retinal nerve fiber thickness is sort of like a window into the brain, and the presence or loss of neurons can be represented by thickness of this retinal nerve fiber layer, and we can follow that over time. But obviously not everybody has access to it. It's just sort of out here as a proposal of something to follow. For lab testing, you can see, because monocytes in general express CSF1R, and there's tissue resident macrophages that in theory could be affected by expression of CSF1R pathogenic variants. So if you follow it over time systematically, you could see whether there's immune dysfunction or other organ system dysfunction. And then if there's vitamin deficiencies that can be supplemented, like vitamin D. And then the last thing, and maybe the first thing that you've talked about, is disease-modifying therapy. And at this point, because, we don't have any FDA approved from the US perspective, disease-modifying therapy, that is a discussion about referral to trial centers. And this is just to review some of the things we've heard already, that because we don't have it, we don't know what the best strategy is. And so there's many things under investigation, as well as experience with stem cell transplant, improving microglia function, cell-based therapy to replace microglia, gene therapy, and this ongoing question of whether the treatments that are out there already that are used in other disorders that could modify are really under investigation, unknown. We have data for some of these, like you'll hear later about stem cell transplant, that we can modify disease in some people, but there's many questions that we still have about it. Other important questions that you have to have at some point, not necessarily at your first visit, is sort of long-term questions. Do you need to establish a power of attorney or medical power of attorney to have someone who will help make decisions that are in line with what you want? You have to ensure that you have access to health insurance and going on disability or other types of insurance options. And you need to have a really good team of experts who can help you navigate these really challenging issues. One option that can actually be done early on is a referral to palliative care. This is a specialty of medicine that's intended to focus on the quality of life, and is a partner that you can have going forward. And then one of the things that I'm just kind of throwing out there is having the discussion of avoidance or aggressive treatment of, say, infection. And that's why it's really important to treat bladder symptoms, for example, so you can avoid urinary tract infections, or avoid dysphagia or having trouble swallowing, so you can avoid lung infections, because any infection can potentially worsen your symptoms, at least in the short term of having the infection. And we don't quite yet know all the triggers that bring on the disease. So just kind of thinking aggressively about that in advance. But again, this is sort of not based on data that definitely shows this, just sort of keeping it in mind. And then, you have other people typically involved in supporting through this journey, and the caregivers and friends and family also need support. So one of the goals that we have is sort of standardizing, and I'm saying neurology because that's what I am, electronic health record template, so that we can keep track of the data and the symptoms and the experience all at the same time, so that it's all available within the clinical record, and that can be immediately transferable to identifying what those biomarkers are that will change to show efficacy in a clinical trial. And I just have this note at the bottom that we have a diagnostic code for ALSP. for whatever reason, I don't know if other people have this experience, when I search for ALSP, nothing shows up in EHR, but I can type in G93.44 and it shows up just fine. So when you go into the visit, sort of incorporating all of the things that we've discussed here, there's first visit questions that you should be discussing. When did these symptoms first start? Do you have this past medical history of triggers, potentially? And some of these are listed out here. And then there's questions that should happen at every visit. Have you developed tremors? Are you having issues with cognition? How far can you walk before taking a rest? Have you had any falls? What are you doing for exercise? Any issues with driving, fatigue, mood issues? Any issues with getting dressed, showering, doing your bills or cooking? And then at medical review systems, any rashes, weight changes, skin color changes. Some of these questions have been developed after talking with group experts. This is not inclusive of everything that you could ask, but just some things to keep in mind. And then the neurologic physical exam might also help identify some of these issues, whether a walking aid is being used, how fast somebody is going. There's different measurements of how fast somebody can walk that you can keep track of over time. And that, like I said, the goal is to integrate elements of a potential retrospective and prospective natural history that's directly extractable from this data. So if everybody's actually answering and asking the same questions and having these same discussions over and over again, we all have access to similar data. Okay, so with all of this together, who should be on your medical team? Because of the types of misdiagnosis that are involved, you're going to end up potentially with a neurologist of some type. So a general neurologist, MS or neuroimmunology, neurogenetics, cognitive specialist, movement disorder specialist, stroke specialist. And we all, if it's a specialist, we all have our area that we're really good at and the other areas that we feel less confident in. And sometimes we have to work together to figure out how to do that. And, just being aware that there's specialties even within physical therapy and occupational therapy and speech therapy and neuropsychologists that can support these different symptoms is really important. You should also have a primary care doctor so that we can work together very closely to keep you out of the hospital if anything comes up. A genetic counselor and possibly a medical geneticist on your journey to get diagnosed for support and also for informing other family members of what's going on. A psychologist, a psychiatrist, or neuropsychologist are really important support. Urology, physiatry, the PTOT, speech therapy, and social workers, as we mentioned earlier. So how frequently should you see your medical team? Our initial practice is once diagnosis has been made, you need a short interval follow-up, within weeks if possible, because, from my experience and from what I've heard from others, once you hear the diagnosis, you're not going to really absorb a lot else. And so in that interim, there's going to be all these questions that pop up. And so you need to really have the opportunity to go back in and ask all those questions, and maybe several times. And I would say after that, it really kind of depends on what symptoms there are reported and what support you need. And so that's really every 6 months at minimum, and maybe more frequently at first. And this should be a series of a combination of in-person and telemedicine visits, if that's possible. And the frequency can be distributed through the multidisciplinary team, because it can get burdensome to see all these specialists at the same time. So you have to kind of work together as this overall care team to make it work and be reasonable. And then you will hear more, and you've already heard that we're always referring to Sisters Hope Foundation. They have this wonderful new diagnosis information, this doctor's toolkit that you can share with doctors who are not as aware of it to help find specialists, along with this up-to-date information for resources, lists of experts, and ongoing clinical research. As part of the Medical and Scientific Advisory Council, we get the opportunity to discuss what do people want from Sisters Hope, what do people in the community need, and what sort of recommendations do we need to make for that. So this is an ongoing discussion, and we welcome input. And with that, I will thank the many, 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 many people that have enthusiastically joined in on these discussions, the patients and families, I am fortunate to work pretty closely with Heidi and Erin with the Medical and Science Advisory Council. It takes a village to do clinical research and many collaborators, and this is a growing list because we are lucky to have so many people that are interested in making this a better experience. So I'll stop there and take any questions.
Yeah, thank you very much, Jen, for this wonderful talk. So are there questions here in the room? Well, Jen, I think it's really clear that you need a multidisciplinary team to treat to adequately treat the patients. But is this reality? I mean, I talked this morning, I talked to a woman from Ohio, and she told me, well, as long as I can see, and you can see wide in Ohio, there's nothing, simply nothing. So she was very much complaining for not having the chance for a speech therapist or an occupational therapist and all these things you mentioned. Yeah, what do you think?
Yeah, I think this is very challenging. I mean, even so, I've had the experience of starting this adult, leukodystrophy clinic, and it's a very different experience than, say, a pediatric multidisciplinary comprehensive leukodystrophy clinic where I can't have everybody in clinic with me at the same time. So I've had to, over years, establish partners who feel comfortable taking care of a disorder that they've never heard of. And I know this is something that comes up over and over again from people's experience. And so, centralizing through Sisters Hope Foundation to really establish those network of partners to find out like the creative approaches that what I have found to be successful for, physical therapy, speech therapy is to ask for help in the context of another disorder that's more common that people have established expertise in. If you say that there's a local movement disorders clinic or a local ALS clinic, local meaning, that there's a range of what I mean by that. But then people have an understanding that if they're going to do that approach, that it's possible that they can provide some level of care. And then we can work with those partners to help understand the experience that they're having on an individual basis, and then provide support to from what we know from the community. So it's an ongoing discussion. It can be an uphill battle, but it's a growing understanding that we all have, and then we also have to do our job to get our recommendations out there so people have access to them.
Yeah, so people at least should present also at the leukodystrophy center as long as they can do that. I mean, later on in the stage of the disease, it's sometimes not possible to travel long distances. But then we need, in addition, some network between the leukodystrophy centers and the local doctors. I think this is a big issue. Yeah. Other questions? Well, I have more questions. Are there medications that are harmful in this disease, or can you just take all medications you need?
So that's an interesting question. I don't know if I completely know the answer to that. I was kind of thinking of some, and this is sort of how I go through my visit with someone in front of me based on the symptoms they're telling me. So, I might be hesitant to recommend a stimulant for fatigue if someone has a history of seizures, for example. But it really sort of depends on the person in front of me. For CSF1R ALSP, exactly. And, if anybody has any input on this, please speak up. I mean, I'm not sure if there's something in particular that I would say is known to be harmful for symptomatic care.
Yeah. What about cannabis?
That's a good question. I think we don't have data to say whether or not it would worsen cognition or anything. I think that we have anecdotal data, I would say, from people that say if it's helping with anxiety or that sort of thing and not interfering in other ways, and you're in a state that has access to it, then why not?
Yeah. Another issue frequently is vaccines. What about vaccines? Do you think that there is a problem with vaccines, for example, Corona or whatever?
So that is an excellent question that we don't have that I'm not aware of, and again, if anybody wants to speak up and say, but I don't think we have data that says it's harmful. And so I think the benefits of not having the infection outweigh the risk of getting a vaccine based on what we know. So I do recommend getting it, but I also keep track in the record of what vaccine has been taken and when.
But wait.
Thank you. Thanks for that wonderful talk. Kind of on that subject, can you? Oh, I'm Yetta.
I think I was going to recognize you by voice, but
oh, that's right, because you can't see me. Oh, yeah, that's okay. I get it. Yes, I get it. So on that subject, I was wondering about your experiences with antipsychotics, given that these patients can have Parkinsonism, and whether or not that really like worsens their symptoms, or you don't really see that based on your experience.
So that is another excellent question to bring up, and something that I should incorporate into this discussion. So I don't actually have any experience with that issue, but what I have done so far is collaborate with a cognitive neurologist who has actually referred patients that we've ended up diagnosing with CSF1R ALSP if any treatment interventions are needed, or the person wants it, or the family wants it, then we discuss all the potential side effects. But I think that's a really important point to keep in mind.
Here's another question for you.
Great presentation. This is Seth. You may have seen me briefly yesterday at a different meeting, but I actually come from a different community, Huntington's disease, but antipsychotics are also utilized a lot in that. But kind of following up on the prior question, do you see any type of just challenges with that? I mean, given that antipsychotics can impact someone's functional and cognition abilities, do you see that there might be challenges, or we'll say maybe I'll be more transparent, but like better educating on the dose levels of antipsychotics based off of that patient's preference and quality of life, I guess?
So these are excellent questions that you know, my head is like the wheels are turning. So like we need to make sure that those questions are asked as part of the to understand what the practices are and what effect that has had. Because like the first pass is I don't know the answer to this question. My own approach always to starting a new medication is to start at the lowest dose and then feedback within 2 weeks or 4 weeks to find out, was it helpful? Are there any side effects before making any changes? You know, some medications you can check a level, but that's because if we're going to go to a medication, we better do it on the lowest dose possible so that we're avoiding any potential adverse effects. But this is something that can be, you know, sort of is anecdotal until we report it, or find out from the natural history studies if there are particular medications that have been used that have been associated with particular symptoms. That's you know, it might be hard, but potentially possible to do a study on that in a rare when there's not so few people available. But I think that there is some information that we can gather on that, but it's a really good question.
Hi, Doctor. Great presentation. My name is Mike. I'm with the ALSP community. What are your thoughts on the study about glucocorticosteroids used as a prophylactic?
Yeah, so I think I kind of put it into the category here of medications that are available that we don't exactly know if it'll be helpful or not. You know, steroids are something that I use all the time in inflammatory demyelinating disorders, but we use them on a very limited basis. And so the kind of clues that we have out there are maybe having some exposure to a steroid could be helpful, but it's on a very limited number of patients with all different kinds of formulations that they received it. So based on what's available, I wouldn't know what to recommend. And because of the side effects, you know, I would hesitate to say, obviously, this is like what we should do. So I end up having a discussion with someone sitting in front of me about the limitations of what we understand, and knowing that it has been posed out there as a possibility. What we need is an actual way to measure, does this make a significant change with something over time? If we were able to do that study, that would be awesome. And I'm not saying I'm sure it can be possible. But there are some people that I think would want to try it, and it's just an individualized discussion because the answers we don't really know.
Yeah, and I think in addition, I'm not sure about the rationale for that. I mean, the corticosteroids are not primarily targeting the microglia. It's more targeting other immune cells usually.
Right.
And so this is, I have problems to understand what the reason is for the rationale for that. But maybe Florian, you have an idea? No. So nobody has an idea. So at least we should really have it in a controlled way to see if this really is helpful, yes or no.
Right. And so at this point, I wouldn't necessarily recommend it, but really it's limited to the discussion of what we understand and not understand about it.
I have another question for the biomarkers. We talked about biomarkers. Is there a biomarker that would indicate that the disease is starting to progress or starting in the next stage of the disease? What do you think?
I mean, an excellent question. So of course, I'm going to start with, I don't know, but the MRI shows that something has shown up already if there's a lesion, right? So is there something that we can identify earlier? Previously something like neurofilament light, which has already shown up, I think Dr. Bergner mentioned it, is now clinically available. As of 2 months ago, I can order it on people. So that is something that I think is worth following over time to see if there's blips in the amount that will tell us that something is happening. But in the short term, we don't know the answer to that. And actually, it can be nerve-wracking to someone to get a lab result back that's high, and we don't actually know what it means. So you have to be very careful with that. I don't know, but I have put out there that the OCT that I test could potentially be another marker that maybe something is already going on that we wouldn't have otherwise measured. But otherwise, between the discussion and symptoms and exam, I'm not sure we have another specific marker quite yet.
Yeah, the background of my question is it would be nice to have a blood biomarker instead of having repeatedly MRIs. So let me more focusing my question, is neurofilament a marker that could be done instead of MRI on a regular basis, and once it's going up, then you do the MRI? What do you think about this approach like this, so you can save some MRIs?
Yeah, so I think because we don't know the answer to the question yet, I don't know if we can necessarily save MRIs, but since we don't actually have any specific recommendations for how often to do it, it's really up to the discussion of what someone's comfortable with doing. I've started checking neurofilament light to see if we can start answering that question, and would love to do it on a more systematic where we're all doing that at the same time to see whether or not that's true. It would be even better if there was like a very specific blood marker to this disorder that would become positive at some point. So that would be another ideal thing. This is a discussion that we have in MS too. We don't know if actually you could just check neurofilament light and avoid MRIs.
Yeah. Oh, there's one more question.
So this is Donald. So you had mentioned one of the things that you're thinking about looking at is OCT for the audience here. Can you explain what OCT is and what do you think you're going to see using OCT?
Yeah, so OCT is a very non-invasive test where you just require the equipment, which we have in our clinic because it was developed for MS. But you kind of look at a little dot, and it's sort of like an ultrasound pulse that measures the thickness of your retina, and then you can take measurements of the thickness of your retina and optic retinal nerve fiber layer around the optic nerve. And it was from my background in it is understanding what's developed in MS, and that people who had this optic neuritis, which is a typical finding for that, have thinning of their retinal nerve fiber, but also other people with MS have thinning with or without that optic nerve thinning. And so I have actually incorporated and I collected on anyone who's willing to do it within our neurogenetics clinic to see if it is a biomarker in this case of say neuronal loss that would represent the thinning, or if it's stable. But you know, that we still need to sort of analyze the data to know whether or not it would actually be a useful biomarker here.
Yeah. So thank you, Janet, for the nice discussion. Thank you for having you online at least. So,
Thank you.
Good luck in Pennsylvania. So welcome again to this ALSP session, part 2. I think we had very nice discussions in the first part. Yeah, so it was a nice meeting. I like it very much. Thank you very much for that. So we start now with Cynthia Cassandro. She's Vice President in Patient Advocacy at Vigil Neuroscience.
Correct.
And she is talking about, together with Tony Turnbull, as Associate Director of Clinical Sciences, and they both are talking about the natural history study, which is very important. It's the first and only natural history study and ongoing clinical trials. So go ahead.
Thank you, Dr. Kohler, very much. There we go. So hello, everyone. As Dr. Kohler said, my name is Cynthia Cassandro. I'm so happy to be here today and very thankful, Dr. Kohler, for you and all the work in putting this session together, as well as Diane and the ULF team, and inviting Vigil to give an update or an overview on our program in ALSP, specifically our natural history study and our clinical trial. And for those of you that may not be familiar with Vigil, we are a clinical stage company that is focused on microglia. And as we've heard a lot this morning, that microglia are critically important to the health of the brain. And as such, being a company focused on microglia, we focus on diseases that are impacted by microglia dysfunction, such as ALSP. So we're very excited and to provide an update here, and we'll just kind of walk through this slide from left to right. So in order to kind of move into a phase 2 clinical trial, there's a stepwise process to get there, and you have to study your investigational treatment in a phase 1 study, which is done in healthy volunteers. That study has been completed. And that allowed us to differentiate the dosing levels of our investigational therapy, which we call iluzanebart, or as a nickname, IBART. And this helps to evaluate the drug safety and tolerability. And what that study showed is that iluzanebart is safe and it's effective and tolerable. So we move into a phase 2 clinical trial, which we'll talk about in a second. But in the middle of this slide, we're going to spend quite a bit of time today talking about the natural history study, because this is where we're learning a lot more about ALSP, and we're able to use this data to look at the clinical trial, because the clinical trial is it is an open label study and not a placebo control. So we look at the natural history study as a comparator. So the natural history study is an observational, multi-center study. So it's occurring globally at centers across the world, following patients or people who are living with ALSP to help us understand the natural course of the disease, hence the reason we call it observational. And what this is doing is bringing us new insights about the ALSP that can guide future research, such as comparing this to a drug study like IGNITE. So IGNITE is the phase 2 clinical trial for people who are living with ALSP. Again, this is also multi-center, open label, and we're looking at the tolerability of iluzanebart, and we're evaluating the effects of iluzanebart and on the signs and symptoms and how it impacts people who are living with ALSP. In the coming slides and over the course of this presentation, we will do a deeper dive on the natural history study. Tony's going to talk more about biomarkers, and we'll just give you a quick update in terms of where we are with the clinical trial and program timelines. So Illuminate, natural history study, the first, as Dr. Kohler pointed out, in ALSP. This is a 36-month study, and the visits occur every 6 months. What we're looking to learn is about how ALSP occurs, really more about the signs and symptoms of the disease and how it affects people over time that are living with it. And what we show here is the assessments that are being done that actually speak to the biomarkers. So the assessments are MRI, that's your brain imaging. We do a MRI every 6 months. We do a lumbar puncture to look at cerebral spinal fluid. We do this once a year. And this is at baseline over the course of the study, 12 months, 24 months, and 36 months. And then we do blood tests to look at the blood proteins, another biomarker. And we do this every 6 months. The Illuminate study is the people who are eligible to participate in this study, which is ongoing, is 18 years or older. You have a confirmed CSF1R gene mutation. You're diagnosed with and are showing symptoms of ALSP, and your MRI findings are consistent with ALSP. The study is taking place, as I said, globally. You can see the locations on the map, and if you're interested in learning more about where these study sites are, you can visit clinicaltrials.gov, or you can reach out to Vigil directly. We realize that there are not study sites that are local to where everybody lives. And so if travel is required for you to be able to participate in this study, Vigil does offer travel assistance and stipends for both the study participant and their caregiver. So that I'm going to turn it over to Tony, who's going to speak about the ALSP biomarkers.
Hi, everyone. I'm really happy to see actually that we've mentioned biomarkers a lot in the discussions this morning. So I don't really have to introduce them too much, but I do know that we're a little bit of a mixed audience. So just so that everyone is on the same page, biomarkers are biological markers or signals that can represent changes that occur inside the body. So they can be measured, and their changes over time can be tracked and used as an indicator of your overall health or function. So this can be in health, in sickness, but also maybe in changes to how your body is responding to therapy, or something like a change in physical exercise or lifestyle changes. Biomarkers can often change very early in the disease process, and this means that they can sometimes be seen before the actual physical or clinical symptoms of the disease develop and can be seen. And physicians and scientists use biomarkers as a way to help understand the causes of the disease, the progression of the disease over time, but also, as I mentioned, the body's response to therapies or to treatment. At Vigil, we're looking at biomarkers in the context of ALSP, at identifying and studying them further, and this helps us understand the really early processes that we see in this disease, but can also be helped us to use biomarkers potentially as a prognosticator of response to therapy, and to see maybe very early if it's helping our patients. In rare disease, biomarkers are often discovered, especially in rare disease, discovered often in natural history studies. And this is what we're conducting. This is where we follow patients over time, and we measure biomarkers at different time points and look at their changes. This, as I mentioned, helps us really understand the disease process. We can essentially open the curtain and have a good look at things that happen early, and can maybe be a more efficient way of looking at treatment efficacy. So as Cynthia sort of introduced, there's a multiple biomarkers that we can look at. We all know that ALSP is a disease of the central nervous system, so the brain and the spinal cord. So what we really need to look at is the brain and how the brain is functioning. And we do that by looking at MRI imaging, so brain scans. And we look at a few different things here. We look at the volume in the gray matter, which is the size of the brain, and also the ventricular volume. And the ventricles are these fluid spaces in the brain that the brain sort of floats in. And so we look at the change in ventricular volume over time, and of course the white matter lesions, which are characteristic of the disease. So these ventricles in the brain, they have this fluid called cerebrospinal fluid, and we look at proteins in the cerebrospinal fluid via an LP. And one of the proteins we look at is the soluble CSF1R, which we all know is the protein product of the gene we know is responsible for ALSP. And so we look at that across the span of the natural history study. And then the last one is the neurofilament light protein, which we've all heard about today, which is more of an acute marker of axonal injury. And we can look at this via the CSF fluid or in a blood test. And so these are all tools in our toolbox to have a look at how this disease is progressing and how we can and a way to monitor it, but also we can see if our patients are responding to our therapy. And if you all give me 1 second, I'd like to dig into one of those specific biomarkers. And so here are some MRI images of a patient in the natural history study. So we have our baseline MRI. For those of you, this is not maybe a comfortable image. This is sort of looking at the slice of the MRI is this way, so the patient's looking at you. The very white outline is the skull, the brain is the gray stuff, and in that middle there you have these fluid-filled spaces, which are the ventricles. And so we measure them, and because this is a 3D, the brain is 3D, we're looking at the height, the depth, the width. And this is a baseline scan at the beginning of the study. And then 6 months later, we can see that as the disease progresses, we see growth of these ventricles, and then again at a 9-month span. So if you happened to pass Dr. Kohler's poster yesterday, one of his images was on how this correlates to changes in clinical progression. So this is where I'm going to end and pass it back to Cynthia, but I hope you can understand that biomarkers are very helpful tools for us as scientists, and especially at Vigil. And we hope that we can continue learning from them to understand the disease. Thank you.
Thank you. Great job. So we talked in the beginning, just kind of recap where the program is. So we have the ongoing natural history study, and we have the phase 2 clinical trial, IGNITE, that is looking at iluzanebart. The clinical trial is fully enrolled, which is fantastic news, and obviously only possible without everybody participating, and it's a collective effort of the entire community. So very just sort of briefly, this I just wanted to give an overview of the study. So this is a 12-month study with an opportunity for further extension. And iluzanebart is administered monthly. It's an IV infusion. And we're evaluating the safety, tolerability, and the effects on imaging and biomarkers that Tony just discussed, and the clinical effects. And as I said earlier in the presentation, this study is an open label study. So there is no placebo arm. And we're working to look at the natural history study to compare how are people doing in the clinical trial versus in the natural history study. So from a timeline standpoint, in the fall of last year, we provided an update on the study. We called this an interim analysis of the IGNITE study. And then up in the third quarter of this year, so coming up in the not too distant future, we'll provide another update to kind of see how things are going with the program. And then the final analysis will we'll announce when that will be, but at some point next year. So what we saw in the November of last year interim analysis on the bottom section of the slide here is we saw that iluzanebart shows a favorable safety and tolerability data, which is fantastic news, enabled us to move the study forward and supports further relevant biomarkers for ALSP disease progression. So this is all very, very good news and promising for the future of this program. And really, basically, the end result here of an interim analysis is that we continue the study and looking at as a potential therapy for ALSP. So with that, really want to just kind of speak to conclusions and next steps. So the Illuminate Natural History Study, the data's taught us about ALSP biomarkers. Tony just elaborated on a few. These are important to increasing disease awareness, understanding the disease progression, and discussions very important with the regulators, with the FDA, with EMA. It really helps us when we have the natural history study to be able to have conversations about what this looks like in comparison to a clinical trial. And then the biomarkers may be seen earlier, as Tony talked about, than clinical symptoms. So these are very important in the drug development process to understand the potential treatment effects of the phase 2 IGNITE clinical trial. And then, as I just discussed, we'll provide further updates later this year on the program. And really, none of this is possible without everybody's participation, and just want to reinforce how grateful we are to the patients, their families, the research team, study investigators, and the advocacy community. It takes a village. So with that, we can answer questions.
Yeah, thank you very much. Thanks here, and Tony. Are there questions?
We do have a couple other folks from Vigil here too, so we're open to questions.
Yeah, you talked about biomarkers, and you write down, and that was new for me, that the biomarkers are indicating disease progression before clinical symptoms. Is that true? Do we have this data?
I'm not sure if that works. We are currently investigating that. Yes.
Okay.
So we're looking at MRI. Our natural history study is
Oh, I mean the blood biomarkers.
sorry?
I mean the blood biomarkers.
The blood biomarkers like NFL,
Yeah.
for example. So our natural history study contains patients that are at the prodromal stage and at the symptomatic stage. So when we're saying early in disease progression, we mean prodromal. And we are looking at NFL and we are looking at MRIs in these patients. So yes, we're trying to understand if any of these can be used as a predictor of progression.
Yeah. But up to now, the NFL is a little bit higher than normal, but it's not.
Yes.
You don't see, we don't have.
There's nothing clear yet.
Okay.
I think we're still looking. Yes,
Yeah.
I'm not. Yes.
Yeah. Yeah, and this would be very important to have a biomarker like this.
Absolutely.
What about the soluble CSF1 receptor? You're only looking at the CSF.
At the moment, we are only looking at the CSF.
Why don't we look at the plasma?
I think that is in the plans to look at.
Another plan that needs to be.
Okay. It's like all scientists. We just need more data.
Yeah, we need more data.
Yes. Yes.
So, other questions?
How long have you been testing?
Wait.
How long have you been testing for the NFLC?
We've been looking at NFL from the beginning. So when our prodromal patients come in, when they meet our study criteria, the first time we look at them is at baseline. And then we track them every 6 months.
When did that capability come to you? Like how long have you been?
From the beginning, so I believe NFL recently has been made commercially available, but in research labs, NFL is of quite of interest in the neurodegenerative field. So it's been looked at for a long time. Yes.
Questions?
Thank you. So more questions? How is the drug working? How is that working?
So I was Anna Martin.
What's the idea behind it?
So it is what we call a TREM2 agonist. So
TREM. What's
TREM.
that?
Okay.
Is it a transport?
It's
transport, right?
Yeah, it's a pathway to support the microglia function. And because CSF1R there's a mutation on the CSF1R, our program is working on an alternative pathway, which we call TREM2. And we're hoping that what it's doing is increasing the effect of that functional pathway, because the dysfunctional pathway is not working. So we call that an agonist of the.
Yeah. And so the alternative pathway can do the same like the defected.
That's correct.
It's a substitute, right?
Sure.
So this is Ivana Levish. I'm the CEO of Vigil, so maybe I can explain it. So there's two receptors of microglia, CSF1R and TREM2. TREM2 is the key damage signal in the brain. So TREM2 responds to damage signals and actually activates microglia into their neuroprotective state so they can actually go and deal with the damage that's existing in the brain. What's happening is that these two receptors share downstream signaling. So the idea here is because CSF1R is mutated, you can't really activate an inactive receptor. So what we're trying to do is by activating TREM2, we're actually trying to repair the deficiency in CSF1R because of that downstream signal.
That's actually a very smart idea, yeah. If it's working. So more questions? No, thank you again.
Thank you very much. Thank you, everyone.
So now, yeah, I think. So now I'm very happy to welcome Troy Lund from Minnesota, and he is, I would say, one of the most experienced expert in the field of hematopoietic stem cell transplantation in various diseases. So we are very happy to have him here for this meeting. Troy, it's yours.
Great, thanks. Let's see if this is working here. That's that. That's that. Maybe I'll stand here. Okay, a lot of this is going to be like a talk on how do we arrive for transplant for ALSP? What is the history of it? And then we're going to talk a little bit about what it is and how it works. We need some definitions to explain, just so you don't get caught up in the vernacular. When I mention conditioning or preparative regimen, that means that's the chemotherapy given over about 5 to 7 days prior to the transplant. So that's the word we use. Engraftment refers to the donor cells going to the marrow and the brain and staying there to reproduce the immune system. So that's engraftment. Stem cell sources. So when you talk about transplant, we get a lot of questions. Well, what are you going to transplant? It's all called bone marrow transplant, but that's just a short term for all sorts of different kinds of transplants. We can have mobilized peripheral blood stem cells. We can have bone marrow. The mobilized peripheral blood cells are obtained by giving a donor a compound called GCSF for 4 or 5 days. That mobilizes the stem cells out of the bone marrow into the bloodstream at tremendous numbers. It's sometimes accompanied by a little bit of a leg pain because it's so robust. Then you hook somebody up to a machine and the blood goes out, it goes in a centrifuge, and all the stem cells spin out in the centrifuge and the rest of the blood goes back in the person. Bone marrow is the more traditional way where you go to the operating room, the donor is intubated, put face down, and we put a couple of needles in each of the backside hip bones. We take off about 10 milliliters each pull, and the goal is about 1 liter. So we're in there for a couple hours. And that's the more classic thing people think about. Recovery is over the next usually 3 to 4 days. It's just the patients describe it as, you know, somebody like punched me in my backside. They have that kind of a soreness. And then there's cord blood. So cord blood's very popular. Our university made it very popular. We do a lot of cord blood transplants. This is where a baby is born and the cord and the umbilical cord is usually sitting there connected to the placenta. You can put a needle in it. You can suck out that blood. You can put it in a bag. You can freeze it for the next 30 years and use it as a transplant source. And so all the people that have donated cord blood, all these cord bloods are sitting in banks around the country. So those are our sources. So we have our sources, but then you have relatedness. So you can have a brother or sister give bone marrow. You have a brother or sister give mobilized peripheral blood. You can have a brother or sister give their umbilical cord blood if they saved it, if the parents saved it, that is. You can have an HLA-related donor, so an HLA-matched donor. So these are the people in the Be the Match program that when we do a search for matching, those are the people not related to you that happen to match you that are potential donors. They can give peripheral blood, they can give bone marrow, and they can also give umbilical cord blood, assuming that cord blood was saved. You can do a haplotransplant. That's a half match. So that's usually from your mom, your dad, or a close aunt and uncle. They can give peripheral blood, they can give bone marrow. I don't think we've been saving cord enough long enough for them to give cord blood. So that hasn't really been done yet. There are autologous stem cells. So you can give your own cells. That's a type of a transplant. You can give yourself mobilized peripheral blood. You can give yourself your own bone marrow. You could potentially give yourself your own umbilical cord blood, assuming you saved it. We do these transplants with your own cells in very specific diseases, not ALSP, but there are some diseases where we do that. Has anyone been transplanted with their own cord blood? Not like I can think of. Maybe there might be one case in the United States that may have happened, but not yet. And we can talk about why. Now you can manipulate it. We can do gene therapy on all these sources. We can expand the sources like cord blood. They're very small. And so there are ways now where we can grow those cells in the lab over 7 to 21 days to make a very large cell dose. So if transplant wasn't complicated, it's very complicated because these are all the things we can do. When you come and see me, these are the things we discuss, all these different types of transplants. Okay, so why do we give all that chemotherapy? That's the most common question I get. Well, I could take somebody's cells and I could give them to somebody else. The physical process is very simple. That's not a problem. But what happens is that you get a phenomenon called hyperrejection. So as soon as I do that, within seconds and minutes, those cells are attacked by the other person's immune system and you get hyperrejection. And so you need to prevent that. It's a pretty robust response. It can be accompanied by shortness of breath and high fevers and low blood pressure. So you don't want that. See, you got to have some chemo to get rid of that old immune system to avoid hyperrejection. What about making space? So this is bone marrow. This is a delicacy. This is cow bone marrow, I guess. I've had this before. I actually don't like the taste of bone marrow. It's very fatty. So I don't know, it's not for me. I tried it a couple times. It's not for me. This is actual bone marrow. This is what it looks like. This is a needle core of marrow. All these purple things here, these are all the stem cells, all through the marrow. This is another way to look at it. This is a cartoon. So you have your round bone. The marrow is just packed in there. It's a couple of blood vessels. If I give you some cells, they got to go somewhere. There's no room in there. So we have to clear that out because you've got to have some physical space. So while the chemo again, prevent hyperrejection and to make space in the marrow. So get rid of the old marrow. And that happens pretty quickly after the chemo. And so finally, then what about this brain and marrow connection? So what is in your skull? It's neurons, of course. That's what we think about when we think about brain, but there's also glia. So glia is derived from a Greek word. It means glue. And this is the stuff that holds the neurons together or supports the neurons. It includes ependymal cells, oligodendrocytes, astrocytes, and microglia, which we talk about a lot because they're implicated in some of these leukodystrophies. And so those are the two big cell types we think about. And of course, what we focus on are the microglia. Microglia are about 10 to 15% of our brain cells. They do lots of little different things. They can take up some of the cellular debris. They can digest plaques. They get rid of unnecessary neurons. They trim connections between neurons. And it's all coming from my favorite medical source, Wikipedia. They really have good summaries. Sometimes I go in and edit them, but overall they're pretty good. Now, unlike neurons, microglia are connected to the hematopoietic system because they have a common origin. So the microglia are kind of an immune cell, and its birth was along with your bone marrow system, if you will. So that's kind of fundamentally why this whole process works. So we'll go back to 1968, about 1969. A lot of things were going on in the world. We had the assassination of Martin Luther King Jr. We had the assassination of Robert Kennedy. We had man orbiting the moon. We had a war in Vietnam. The Tet Offensive occurred then and changed the direction of that war. But there are other things going on at the time. One was an accident in a tissue culture dish where an investigator put a cell that was missing an enzyme in one dish, and they were supposed to put another type of disease cell in another dish, but they ended up mixing them together. And so they had two different diseased cells in the same dish, and they were measuring the amount of storage material these cells were chewing up. And it turns out when they mixed the two cells together, the cells compensated for each other. So the cell that was missing enzyme 2 had enzyme 1 and chewed up all the stuff it was supposed to. And the cell that was missing enzyme 1 and had enzyme 2 chewed up its stuff. And the cells all remained very healthy. This was a fundamental discovery at the time. And along in the same year, we have Robert A. Good and Gauti publishing the first successful bone marrow transplant in the world, which was at my institution, the University of Minnesota, in a kid with immune deficiency syndrome. So it was the first time somebody survived a transplant. These two things, one was in Lancet, I think the other one was in Science. A lot of people at the same time came up with this idea, is that, okay, now we can do potentially a bone marrow transplant. What if we got unhealthy cells? What if we got healthy cells, the donor cells, in next to unhealthy cells, making enzymes that the one person was missing or was defective in some pathway? Would those healthy transplanted cells correct the unhealthy cells? And that's where it all started in the late 60s, was this idea of correction of metabolic diseases. So we go back to, why are we doing this again? Remind me how we got to brains and transplanted cells. In this paper, back in 1979 now, fast forward 10 years, they were looking at carbon labeling monocytes in the blood of rats to see where they went. And it turns out when they sacrificed the rats, some of the monocytes they found were carbon labeled were in the brain. It's actually the first paper that showed that there was a cell type you could label in the blood that somehow ended up in the brain. It wasn't very frequent. There was no transplant. It was extremely rare, but it was the first time ever you could find a hematopoietic cell in the brain. So that's where the connection came from. So then fast forward now to the next year. Did someone try to do this transplant for a metabolic condition or somebody missing an enzyme? Well, in 1980, this is the first mouse transplant. The mouse had a deficiency in beta-glucuronidase, which is a mucopolysaccharidosis. These mice and children, they miss an enzyme. And these investigators took upon that idea to say, all right, let's transplant these mice and see what happens. Turns out the mice actually came out very well after the experiment. They had restored their enzyme activity. They had better growth. They had a much better course in their lives than they would have without transplant. And it was the first time we saw this so-called cross-correction of donor cells to unhealthy cells. And then in 1993, as further evidence, Dr. Bill Krivet, who pioneered many of these transplants for cerebral ALD, for metachromatic leukodystrophy and other diseases, looked in brains of female patients who had died for some reason not related to transplant, but they had gotten a transplant from a male donor. And he thought, I wonder if I could see male cells up in the brains of the female patients by tagging the Y chromosome. And it turns out he was right. He did see a few male cells up in the brains. And then what is he pointing out here is this thing here, this black blob in a background of black blobs. This makes no sense to me. Like, this is really how the picture looks, but it's true. That's supposed to be, and they identified this as microglia. So they said, this is a male microglia. It could have only come from the donor. So this was one of the, again, the first papers that gives you direct evidence that after transplant, there are cells that get up into the brain and become something like a microglia. So then we got much more fancier. In the late 90s. We could actually take in mice, we can take mice, use mice that have donor cells that turn blue with a dye. And you could take those special cells, you could put it in a mouse that's white and not marked. And then you can sacrifice the mice. You can look at the brains, section them up, stain the brains to see if there are any blue cells. And lo and behold, you got lots of blue cells surrounding the brain. So there are definitely donor cells up in the brain. There's some kind of a microglia, but again, some of the first evidence that it actually happens. So now a really fast forward to work from Seattle and my lab that showed both that chemotherapy is absolutely necessary for donor engraftment as we think about it today, or radiation. We use chemotherapy. And we were able to count how many cells are in the brain. So the Seattle group focused on humans, and these again were female donors who or female recipients who died after transplant but had gotten a transplant from a male donor. So they counted all the microglia that had Y chromosomes, and so what is the rate of transplant? How many microglia are you actually fixing? It turns out under standard conditions, it's about 8%. And we'll just pay attention to the first bar, because it's about 8% under usual transplant conditions. It's not very much. It seems to be enough, though, to put a lot of these neurologic diseases in remission. We did the same experiment in mice in the same time frame. And what number did we get? We actually also got 8%. So our mouse model perfectly recapitulates the human study. And kind of this is what we study in my lab is, how does this happen, and how do we make it 10%, or how do we make it 20%, or how do we replace all the microglia? But it turns out it's about 8%. So going back, why do we give all that chemo? Eradicate the old immune system so we don't have hyper-rejection. Make space in the marrow so there's room, and then, just as I showed you, to engraft the brain. Thus far, like I said, the chemotherapy is mandatory. If you go down on the chemotherapy, you actually lose all your brain engraftment, which is something we showed in that paper. If you go up in chemotherapy, you actually get more brain engraftment, but there's other costs to getting more chemotherapy. So what we try to do is get the right amount of chemotherapy to put somebody in remission from their disease. Okay, so now back to ALSP. So I don't have to go into all the diseases. I'm not going to show brain pictures or slides or pathology, but it's there's ongoing white matter damage in the brain. It's a leukodystrophy. Inflammation is probably a component, certainly. Microglia dysfunction is probably a component involved in that inflammation. And of course, we wouldn't say there's probably other cell types that play a role. The astrocytes may play a role, the oligos, but we talk about it in terms of this inflammation of microglia because it's easy for us to understand. So there are examples of other leukodystrophies treated with transplant. Like, how do we get to ALSP? Well, for about 10 to 15 years, we've been treating all sorts of different leukodystrophies to engraft the brain to do this cross correction. And those would be metachromatic leukodystrophy. Adrenal leukodystrophy is a big one we do. There are all sorts of bizarre storage disorders that affect little kids where transplant works great. It helps correct their brain, like MPS 1, MPS 2, MPS 6. Some of them are not leukodystrophies, but they still have neurologic damage, and the transplant can correct that to some extent. And there might be other diseases that I'm leaving off here. I'm sure there are. So here's the seminal paper we have to blame for transplant for ALSP. It was Florian and his colleagues wrote up a paper. They thought they were transplanting a patient with metachromatic leukodystrophy, or MLD. When they went back and analyzed the blood, it turns out the patient did not have MLD, but they found mutations consistent with, or the DNA had mutations in CSF1R. In fact, the patient had ALSP and not MLD. And their conclusion was the patient actually stabilized after transplant neurologically. And so this wasn't that long ago. And after this came out, that's kind of when my phone started ringing. Will you consider ALSP patients for transplant? And of course, we had experience with adults with cerebral ALD, kind of the cousin to this, and the outcomes are pretty good. And I said, sure, why not? I don't know exactly how it works, but it seems reasonable to attempt, given there were no other therapies at the time. All right, so what's it like? You're going to get sick because it's chemotherapy, which is essentially poison. And so it's not much we can do about that. We can give you the best anti-nausea meds and try to make you feel better. Adults tend to get a little more nausea than kids do. So for some reason, kids are resilient to this. But most adults get through the week of chemotherapy without too many problems. You get to be on some anti-rejection drugs for about 6 months after transplant, and then those come off. We always worry about infection. So that's one of the big side effects of the risk, because you give all this chemotherapy, you wipe out the bone marrow, you wipe out the immune system, that opens you up to the risk of infection. That could be a virus, that could be the common cold, that could be a bacteria, it could be a fungus. We don't put people in bubbles, but we do the best we can to kind of keep people as healthy as we can. We use a lot of antibiotics to fight these things, and so on and so forth. That's probably one of the biggest first important risks is infection. I mentioned the antibiotics, and there are some other medicines, because for our anti-rejection drugs, they raise your glucose. Sometimes you have to be on a little insulin. They raise your blood pressure, so then you have to take a medicine to lower your blood pressure. Sometimes it takes 2 medicines. They screw up your electrolytes, so sometimes we need to add magnesium, calcium. So it's not uncommon for someone to walk out of the unit with a bag of medicines, somewhere between 6 to 12. But over 6 months, we hope to peel those all back so that you're not on anything, basically. That's always the goal, is to get off all these medicines and get the patient back to where they came in. What else is important to point out? You could progress. So just like a patient with leukemia or lymphoma who could progress after transplant, it's no different for a patient with a neurologic disease. The intensity of the transplant, sometimes you do get some progression in their symptoms. Why that is, I'm not sure. I think there's a lot of weak neural connections and weak neurons, and the chemotherapy doesn't help that. Probably hurts a little bit. Hopefully you don't progress, but it's possible that you progress a little bit in symptoms before the disease is halted. So I tell everybody that. What is the goal? Why do all this transplant stuff? It's really in the case where there's no other treatment for the disease, it's to slow progression to a very low velocity or stop it altogether. And those are the words I use. Stop it or slow it down. The other goal is to retain neurologic function. People want to be mobile. They want to be able to take care of themselves. They want to have all their cognitive faculties. We want to stop the white matter changes from progressing on the MRI, like we talked about with the biomarkers. We want to extend life. So just like some adult with leukemia and lymphoma, we kind of know what the survivability is of that. And so, for transplant, we want to push beyond those curves and offer persons a long life, and also retain good quality life, which is always extremely important to consider, is what is that life going to look like in terms of quality. So does it work? So the cases are not a lot. There's probably about 20 worldwide. Our group and the group at Mayo have written up about 15 of the patients. You can find this article. All the patients are mostly described from beginning to end. The median age for transplant for these persons was 43 years old. An example of the scan of what we might think of as successful for biomarkers are, this is a pre-transplant MRI, larger ventricles in this patient, white matter disease shown here. 2 years post-transplant, not a whole lot has changed as interpreted by our neuroradiologist. Considered mostly stable, in fact, after transplant, which we would view as disease arrest, slowing in progression. And so that's the goal, is to have that kind of an outcome. What about everything else? Just, you know, the MRI is one thing, but what are the patients like, or what is happening? Some of the patients had worsening of their dementia. If they came in with the start of dementia, sometimes that gets a lot worse. And that's a big problem. Some of the patients had neurocognitive scores that remain the same or get worse. Does anybody get better? I don't think I can honestly say that after transplant, you gain a bunch of IQ points, because that's never the goal for any of these diseases, even the pediatric ones. I never tell any family that the child will be better. The goal is to keep them where they're at and not get worse. But so if you can keep your same test scoring ability, that's great. Walking, gait, and balance issues can deteriorate, can be mild from not having a limp to having a limp, from having a gait abnormality to using a cane, perhaps having one cane to going to two canes. Some people end up in a wheelchair. Some of that's unpredictable. Sometimes their gait is fine and it stays the same. And it's hard for me to predict who's going to do what, given only 15 patients we've reported on. There's this consideration by many experts in the field that patients with motor symptoms seem to fare better than those with more cognitive symptoms. So some people say the motor symptom disease is a bit milder than the cognitive disease, but I let the neurologist debate that out. So I'm just a dumb transplanter, so I don't know much. What do you need to be aware of? I always tell people there is a mortality rate. It's not 100% survival, it's about 90%. So it's pretty good. Transplant gets better every half decade. So it's been getting better for the last 20 years. There are side effects that I talked about. Progression, I always remind people you could progress. You need a caregiver. When it's a child, they always generally have parents, so it's less of a discussion. When it's an adult, there needs to be another adult around, because it's the patient doesn't feel great, and they got to keep track of a lot of meds, and the meds have to be taken on time, and etc. So there should be a caregiver to get them through that post-transplant process while we're getting them off all the medications and getting them healthy again. They need to be healthy. Healthier the better. Early in disease, which was discussed already, I would say first MRI change is clear criteria for me, because the earlier you go to transplant, the more abilities you have and the more you'll come out with. I'm starting to wonder maybe even early symptoms is enough. If you can legitimately document some deterioration in neurocognitive function, maybe that's enough to consider transplant, because that means there's an active disease process in my mind. Younger people do better. I don't know why they do. They just do. If you're 60, you do better than you're 70. If you're 40, you do better than you're 60. If you're 20, you do better than you're 40. So it's complicated kind of set of questions, but younger people do better. And that's all. Thanks.
Okay, there are questions for Troy. Yeah, over there.
Thank you. So why might have the ventricles decreased or become more normal in size for that person post 2 years after transplant?
I think you can have some swelling of the brain initially, and transplant can ameliorate some of that and stabilize it or reduce it. We see that in several leukodystrophies, not just this one, that can happen.
And then my other question was, is there an estimate of a mortality rate or around for younger people? Is the 90% just the entire aspect, or is there like a higher kind of survival rates for those?
I would use 90% as an overall estimate for survival, 10% mortality. Obviously, I wish it was 100 and 0, but that's it's just not true. And some adults come in with prior infections. Some people have all sorts of things go on in their life, don't have a healthy lifestyle. They may come in very obese. They may come in smoking 3 packs a day. Those aren't great things to go into transplant with, and that contributes to some of that 10%.
So is the mortality rate or the risk at all, is this dependent on the quality of the donor?
Oh, it's a good question. People are starting to look at that, actually. Thus far, we don't have direct data that the quality of the donor matters. There are different donor types we avoid. Who's the best donor? The best donor, 19-year-old male who smokes a pack of cigarettes before donation. It's great, loaded with stem cells. All right. But don't tell anyone about the smoking part. But it's actually true. Not a good donor, a 35-year-old female that had 6 children. That's kind of at the lower list because the 6 children has changed her immune system. It can actually get some crazy immune reactions. So those donors are a lot lower for us. So the multiple births in females.
Yep.
Well, I have a question that's maybe to both speakers. For a long time, stem cell transplantations were the only interventional procedures that were possible, but now with new treatment possibilities coming up, how do you view the combination of the two of those?
You mean, how do you present them, or how do you, like, they're not done in tandem, obviously. So
But how do you, for example, for a patient, determine whether a transplant or a therapy, or maybe a combination, a therapeutic intervention after a transplant, or?
Right. Yeah, that's part of the consent process. So it ends up being long discussions with the family. And I can tell you, for this disease and this study, I think if you're going to be part of a study, like Vigil has the study on this, you need to be true to the study and enroll it. And so I counsel the families and I explain the Vigil study, I explain the transplant. Obviously, getting an antibody is pretty benign, frankly, right? We do antibody therapy all the time. That's great. Transplants is pretty tough. And so I think most of the patients have chosen to be on antibody and not transplant at that time. And they know full well they could come off study, right? They could say, you know what, I don't think this is working for me. I'd now like to go to transplant. So I don't take anything away from them. I say, I'm always here. If you want to revisit transplant, or you don't feel like things are going well, or for some reason they can't go on study, I'm always available. So I try to keep all options on the table for them. That way they always have everything available.
Troy, there's a question online. Thank you, Dr. Land. From a hematological perspective, can you conceive any situation where second transplant would be considered?
Second transplant, so 1 and then 2. That's really hard. I've written probably 4 or 5 papers on second transplants in leukemia and lymphoma. It's really hard on the body. You can consider it. The survival rate is pretty low. I think 20% or less. And that's in children. So in adults, you've got to have the perfect transplant candidate for an adult to do it twice, because once is hard enough. And the further you can get between the transplants, the better. And if you do, we've done transplants 6 months apart in children, it doesn't end well. I mean, I had a child literally die last night, my own patient, in his second transplant because his leukemia came back. And so he had no choice. There was second transplant or it was nothing. So we did it, but he didn't make it. And that's the worrisome. So yeah, if you can get, years between transplants, maybe then you could tolerate it, but it's very risky.
Yeah. But are there patients that lose their donor and then you need to transplant again?
Occasionally we have children with cerebral disease, and I believe we have 1 or 2 adults that we did have to do that. The other thing that happened was the brain kept progressing. So we thought, okay, you either have to do a second transplant or or we just leave you progress. And they opted to do the second transplant. But again, it's a high risk game.
Thank you for your talk. I have a question about the delay between the effect of between getting the active transplant and then the therapeutic effect of disease stabilization. Can you talk a little bit about what your thoughts on why there's that delay and if there's any research into how to minimize that and get the therapeutic benefits potentially earlier?
Right. I think part of it is the delay for engraftment of the brain, because that takes months. It doesn't like pop in there. It's month on month on month. So that's the 3 to 6 month process to get the new cells in the brain. And so we scientifically work on questions in the lab, how to speed that up. The other thing, especially in ALD, is that the neurons that come in with the patient, they're on their last firing, is how I can like imagine it. They're very weak neurons, and it takes so little to push them over the edge. And since the transplant doesn't replace the neurons, I imagine that those neurons continue to die off until stabilization occurs. And so while those old neurons are dying off, that's why you see the progression.
But this is probably depending on the state of the disease.
Yeah.
I mean, yeah.
For sure.
Thank you again very much for telling about us all the risks of these treatments. So it's not an easy treatment. But I want to ask you, are these risks persistent, or is it a time frame where we have this risk to take the risk, and after that everything is stabilization?
Oh, that's a good question, actually. So we have milestones. Most of the risks are the first 3 months. That's the big period. That's what we call our TRM 100-day window. If you survive that, things are going to go pretty well for you. Neurologic stabilization, I think that's more in the time frame of 24 months. So even a year, but more like 24 months. Where you're at 24 months post-transplant is where you're at. So I think those are the two big ones I think about.
Yeah, well, this is good news. So if you make it to let's say to the first or second year, then it's good.
Yes, definitely good. And it's actually true for like leukemia and lymphoma too, for some odd reason. But
okay, Troy, thank you very much again.
Sure.
So now I'm happy to introduce Erin Sullivan. She's Executive Director of Sisters Hope Foundation. And yeah, I'm very much looking forward to your speech. Okay.
Good morning. Can everybody hear me okay? I'm so happy to be here today, and I am so thrilled to see a wonderful turnout at the ALSP session this year. We've had some really fantastic scientific presentations, but I'm going to pivot a little bit, and we're going to focus in more on the personal side of things. Come on in, guys. So as Dr. Kohler just said, my name is Erin Sullivan. I am the executive director at Sisters Hope Foundation, which is the global advocacy organization for ALSP. Today, I would like to speak with you about this topic, patient advocacy. When someone asks me what I do for a living, I usually answer, I'm a patient advocate working on behalf of a rare disease community. And this answer is generally met with blank, confused stares. So I've been in search of a clear, concise definition of patient advocacy. When I distill down everything that I do any given day and week, my tasks, meetings with doctors, meetings with industry partners, support group meetings with caregivers, private conversations with patients, social media brainstorming, fundraising work, and whatever else needs to be done for the sake of this community, it is clear to me that advocacy consists of 3 actions. Advocates help, advocates comfort, advocates intercede for others. So we're going to unpack this a bit today. First, advocates help people understand the disease, specifically ours, ALSP. Whether it be the patient, care partners, families, doctors, researchers, industry partners, legislators, or strangers on the street, advocates educate on all aspects of the disease. This includes disease signs and symptoms, causes and risk factors, how ALSP is diagnosed, potential treatment options, available clinical trials, the current state of research, where to locate expert doctors, how to prepare for doctor's appointments, and how to manage daily life with ALSP. Helping people understand ALSP also includes creating and curating educational resources like our caregiver manual, our doctor awareness mailings, presentations, and even social media posts. And these are powerful tools that we use for raising rare disease awareness among the ALSP community, as well as the general population. In creating these resources, advocates must take complex scientific ideas, like we've heard today, and we have to translate them into the vernacular of non-specialists. And this is especially pertinent when we consider that these resources are the way that so many newly diagnosed patients and their families and non-expert community clinicians learn about ALSP and understand the intricacies of living with this rare disease. There are, of course, challenges to helping people understand the complexities of ALSP and the patient journey. For as much as we know about the disease, there's still so much we don't know. The general public easily confuses ALSP with other more well-known neurological diseases such as Alzheimer's, FTD, MS, and it even shares part of its acronym with ALS. Don't even ask how many times people get ALS and ALSP confused. Sometimes it's easier for people to grasp something that is more common than trying to understand something that is rare. Another challenge is the genetic component of ALSP. Patients and families often are overwhelmed by this part of the disease. Genetics for most people is a dark labyrinth, and helping people, patients, caregivers understand the implications of genetic testing is hard. There are potential practical repercussions that come with genetic testing, like the ability to qualify for life and disability insurance. There are family dynamics that people must contend with when considering genetic testing, and there are emotional consequences that accompany genetic testing. The advocate acknowledges these and other challenges and works to mitigate them so that they can accomplish the first action of an advocate, helping people understand the disease. Second, advocates work to comfort patients and their families as they navigate the sorrows that accompany an ALSP diagnosis. At Sisters Hope, we provide comfort in a variety of ways. We hold one-on-one support group meetings. We hold support group meetings. We have a private Facebook group where our community can come together to ask questions, to commiserate, and to find understanding with others who face the same disease. We make a variety of digital resources available, and we have now hosted 2 annual ALSP conferences at which patients and caregivers can interact with other patients and caregivers. There are challenges as advocates seek to comfort patients and their families. Many, if not most, patients and families are unaware that patient advocacy groups like Sisters Hope even exist. And even if they do know about Sisters Hope, it's hard to reach out for the help and comfort that they need. Being emotionally, mentally, and physically tapped out, it's easier for patients and care partners in light of self-preservation to just hunker down and focus on surviving the day, the hour, the minute. Support group meetings aren't always a priority as caregivers, for caregivers after a long day, a long week, a long hour of caring for their loved ones and themselves. Again, the advocate acknowledges these and other challenges to provide comfort, and we work to minimize them so that the second work of advocates, comforting, can be done. And we always emphasize the comfort that we can give. People are working on treatment options and towards a cure. We also affirm that people are not walking this journey alone. We provide comfort that we will be walking this path with them. And when they have found Sisters Hope, they found a community that provides help, comfort, and hope. Finally, Advocates act as intercessors for the patients and all those needed to participate in their care and well-being. Advocates communicate the patient's needs to their doctors, nurses, and therapists so that they can receive the care they require for their health as well as their quality of life. Advocates ask about the possibility of off-label treatments that may provide benefit to the patient. They navigate the complexities of insurance policies. If the patient must enter a care facility, an advocate evaluates facilities to find one which will accept the patient, take time to learn about and understand the disease, and provide the compassionate care the patient requires. Advocates also intercede on behalf of the patient with researchers and industry partners. Researchers and industry partners want to know, and they need to know, the effects of the disease so that they can design appropriate research studies that will be useful in formulating effective treatments. Advocates communicate and illustrate the patient experience, which provides researchers with necessary data. Researchers and industry also need patients to participate in studies and trials, and the advocate acts as a bridge between the patient and those running any particular study. Advocates also intercede on behalf of the patients with legislators. This can range from bringing awareness of ALSP to the wider community by submitting proclamations or resolutions to working with legislators to craft bills that allow doctors, industry partners, and care facilities the flexibility that rare disease care and treatments require. There are challenges advocates face as they seek to intercede. Advocates face head-on the maze of bureaucracy. Whether it be the healthcare system, the drug development process, or the regulatory system, these are difficult places to work in. Patients often experience roadblocks to their treatment and care. Medications and therapies necessary for quality of life are often denied by insurance. Many patients have to fight for months to be approved for Social Security disability, and patients do not receive Medicare until 2 years or more after being approved for Social Security disabilities. And many ALSP patients don't live long enough to even see this benefit. While regulations are necessary in the drug development process to ensure that drugs are safe and effective, the process isn't necessarily conducive for rare disease drug development. Rare disease communities have different research and clinical trial needs and capabilities than larger disease communities, and advocates intercede to make these needs and capabilities known so that resolutions may be found. Accomplishing any initiative in regulatory affairs is also a long, arduous process, and it usually requires knowing the right people to help carry the bill through and get it passed. Again, the advocate acknowledges these and other challenges to productive intercession and works to overcome them. The work of interceding on behalf of the patient is the final way in which the advocate advocates. So this is my working definition of patient advocacy, although I do reserve the right to amend it in the future. But a patient advocate is a helper, a comforter, and an intercessor. That's what I do. I help, I comfort, and I intercede for people and families afflicted with ALSP. But I've been doing patient advocacy long before I began working at Sisters Hope Foundation. I got into advocacy 5 years ago, April 2019 to be precise. At that time, I was a busy and content homeschooling mom of 3. My days were filled with teaching phonics and creating art projects and scavenger hunts to engage my kids. But then my grandfather passed away. The kids and I flew home to Kansas to mourn my grandfather and help my parents prepare for his funeral. We walked into my childhood home, and one look at my mom told me she was sick. And it wasn't just a minor cold or an easily treatable illness. I knew with one glance that she was sick with a progressive neurological disease. And how did I know? Nearly 3 decades before my maternal grandmother was diagnosed with a then unknown neurological disease. I was, of course, a child at the time of my grandmother's diagnosis, but my family was tight-knit, so I was aware of the changes and life disruptions that came with such an illness. My childhood years are filled with memories of her mental and physical deterioration, the financial burden that my grandpa struggled with, even to the end of his life, to provide the care that my grandmother required, and my family's difficulties coping with the loss of one so integral to the family. 2 years after my grandmother's passing, my aunt, grandma's oldest daughter, started showing disturbing neurological symptoms. My family wondered if this could somehow be related to my grandmother's illness, but doctors assured my uncle it was not. But yet again, I watched my aunt succumb to physical and mental deterioration. I saw my uncle struggle to manage the extremely high cost of providing my aunt with proper care, and I experienced firsthand the difficulties of losing yet another family member to a devastating disease. So when I saw my mom in April 2019, I knew beyond a shadow of a doubt that she was ill with the same disease that had taken the lives of her mother and sister. And the future years flashed before my eyes, and I knew at that moment life would never be the same. And I knew that because I'd already witnessed this particular scenario play out twice before. While I didn't have a name for the disease, I knew its symptoms. I knew the havoc it would wreak on my mom's mind and body, and I knew the toll it was going to take on my family. Like her mom and sister before her, my mom had a progressive, degenerative neurological disease, and it was going to rob her of her mind and her body, and ultimately it would take her life. In April 2019, I became a patient advocate. I was determined to help, comfort, and intercede for my mom at every opportunity. It took 3 years of advocating for my mom before she finally received a correct diagnosis in the form of a genetic test confirming a mutation in the CSF1R gene causing ALSP. While there was a short burst of relief at this confirmation, my family finally had a name for the disease. The relief was quickly followed by fear and sadness. My family now knew that it was indeed a genetic disease that had taken the lives of 2 women we loved and was taking the life of a 3rd. Plus, the genetic test explanation was very clear. Every child of an affected parent had a 50-50 chance of also inheriting and developing ALSP. It was while advocating for my mother that I met the brave, fierce patient advocate, Heidi Edwards, who in her quest to become a beacon of hope had founded Sisters Hope Foundation. What I was doing for one person, my mother, Sisters Hope Foundation was doing for countless others. Sisters Hope Foundation offered help and comfort that only those who have been affected by this disease can offer, and it gave me tools for helping, comforting, and interceding for my mother's care and quality of life. My mother died of complications from a seizure in August 2022. She no longer needs my advocacy, but others do. So for the past 2.5 years, I have been working with Sisters Hope Foundation in one capacity or another. Previously, I advocated for one person, my mom, whom I love dearly. And I knew the road ahead of her was going to be filled with all sorts of struggles. And I wanted to walk with her, to help her, to comfort her, and to intercede for her. In short, to be her advocate. But now I advocate on behalf of all families, including my own, afflicted with ALSP, because I know their journeys are also full of struggles and they need someone to walk with them, to help them, to comfort them, and to intercede for them. This is my story of how I became a patient advocate and how I have come to define what advocacy is. But this definition expands beyond the scope of a professional advocate. It encompasses what all advocates do. And I've learned in my 5 years of advocacy that anyone who helps, comforts, and intercedes on behalf of the patient is an advocate. Every single person in the ALSP space can be a patient advocate. You are all patient advocates. Whether you're a patient or a care partner, a doctor, a researcher, an industry partner, or a legislator, you use your specific role in this community to help, to comfort, and to intercede for the ALSP patient. So what is your story? How did you get into advocacy? Was it a choice? Was it thrust upon you? How you got here is unique to you, and how you use your position to advocate is also unique. Just as a professional advocate's role is important and necessary for the ALSP community, so is yours. So it's obvious that care partners advocate for patients. You, the caregiver, help the patients in the most basic and necessary ways: bathing them, feeding them, dressing them, the humble things of life. You comfort them by lifting their spirits when they're down and making sure that they know they're loved each day. You intercede for them. You are their voice when they can no longer speak for themselves. You share their journey and you fight to increase awareness, get them the best possible treatment, and ensure they have the best quality of life. Care partners do this because they love the patient and they hope for a day without ALSP. To the doctors, you are a patient advocate. You work diligently to find and give the right diagnosis so that the patient can receive the care that gives them the best quality of life. You educate your colleagues about ALSP so they can do the same. You think outside the box and take chances on off-label treatments to provide hope and life. You use the latest knowledge and research to provide the best possible methods of symptom management. You connect families to patient advocacy groups like Sisters Hope so they can receive the support and community that they need as they navigate life with a rare disease. You work with researchers and industry partners to find better treatments and hopefully one day a cure. To the researcher, you are an advocate for the patient. Your work builds the cornerstone of disease understanding and treatment development. The knowledge and understanding you uncover and share is what leads to better symptom management, better treatments, and eventually a cure. To the industry partner, you are an advocate for the patient. You dream big, building companies whose goal is to find treatments for rare disease. You take chances, sometimes at great personal cost, by using the latest research and translating it into viable treatments. You motivate those in your company by consistently keeping the patient and their journey at the forefront, always keeping in mind that this work is personal. You are on the front lines of improving the quality of life of so many, and one day, saving the lives of those who suffer from ALSP. To the legislator, you are an advocate for the patient. Your voice and influence matters. You make a difference each time you vote for elevated awareness, more research, better access to insurance, affordable medications, and cost-effective, compassionate care. Finally, there is the person for whom all this advocacy exists, who are themselves advocates, the patients. Patients, you are advocates. You help by educating yourself and others. You give comfort to others enduring the same illness. You intercede for your own care and well-being. And even if, because of the devastating effects of this disease, you are unable to do anything else, you inspire others by being a living example of hope, bearing your illness with strength and endurance. Each of you, the patient, the care partner, the doctor, the researcher, the industry partner, the legislators, help, comfort, and intercede for the patient in your various roles. Each of you also faces the challenges of advocacy as you work to give hope to families living with ALSP. Just as the professional advocate faces job-specific challenges, so you endure unique challenges specific to your vocation. When these challenges arise, and they will, how will you overcome and continue to advocate for the good of the patient? Just as the professional advocate is motivated and spurred on by compassion and hope, so too, compassion and hope will inspire you to continue your good work of helping, comforting, interceding, in short, advocating for the ALSP community. And most importantly, we will continue to combine all of our advocacy efforts. We are individual advocates who have joined together to advocate for this very special ALSP community. Working together, we can aid each other to overcome any challenges that arise. Together, we will move forward with compassion, using our individual and combined roles to keep helping, keep comforting, and keep interceding for those living with ALSP. And we will do this with hope. Hope for treatments, hope for a cure, and hope that no one walks this journey alone. Thank you.
Yeah, thank you very much. So I don't think we have questions. I think it was really very impressive to hear it from this perspective, not only from the scientific point, but I think with this meeting, we had very beautiful and wonderful speakers, and I want to thank everybody who was participating here in this workshop. And I think we heard a lot about how to recognize this disease, how to diagnose it, and how to treat it, at least ideas how to treat it. And this is more than we can expect, and we can expect more in the future. So thank you, everybody who is participating here. Thank you very much for being here for the discussions. I think, of course, the ULF for making it possible here to have this meeting again this year, and of course the sponsors that make it possible. So thank you, everybody. Have a nice day and make the best out of it.